So what we'll do is we'll just try to go over a kind of a generic garden variety case that all of us see every time we're on call. And I'll be asking the other panelists for some of their comments and opinions. I encourage the people in the audience also to type in some of their comments about how they do this. So it's a 60-year-old gentleman riding his bicycle without a helmet. He gets hit by a car. I apologize for the fracture appearing twice. He got a fracture of the left tibial plateau, the left wrist, and a couple of rib fractures on the left side, but no spine injuries, no injuries to the chest, abdomen, pelvis. Hemodynamics are okay, labs are okay, nothing too remarkable there. So neurologically, he's localizing, not moving his left side as well because of wrist fracture, but seems to be moving it pretty well. He's not opening his eyes, and he's intubated. Pupils are equal and reactive. So head CT, 3 of the relevant slices are here. Down here is most remarkable for left temporal contusion, a little bit of subarachnoid blood there, some blood along the tent. A little higher, you see a subdural hematoma here, and again, possibly the contusion there. Up higher, again, subdural hematoma, some effacement of the ventricles there on the right. So, question is, what to do? Let's go back to that slide so you have something to look at. Dr. Ramonda, what would you do with this gentleman?
I think the first thing I would do here is, look at the role for placing a ventriculostomy in as a means to both monitor and drain CSF. His GCS is such that you'd like to place a monitor. Probably the biggest bang for your buck is going to come from a ventriculostomy. He does have fairly tight ventricles here, so that might be a little bit of a challenge. But his subdural is pretty thin. There's not a lot of shift. The brain does look very tight, though. As far as I can tell in these selected images, the cisterns are still open, so I think it would be probably my first.
Dr. Rabb, would you agree, disagree?
I would agree that probably the first step would be placement of ICP monitor. And at our institution, our first line is a Camino bolt, and take it from there.
Okay, Dr. Shutter, anything to add?
Our group here would place some type of intracranial monitoring device and see how he does over a period of time.
Well, you're still in the emergency room seeing this guy, and then the nurses call you back to the bedside because he's starting to have much less movement of the left side and the left arm. He was almost localizing, or essentially localizing before with that. Now he's clearly asymmetrical. He's still trying to extubate himself with the right, but he's not even lifting his left arm off the bed, not moving his left leg as much. Does that change anyone's plan?
I'd probably consider getting a repeat scan to see if there's been enlargement of the subdural.
Well, you get one and it shows the subdural is bigger. It's bigger than it was on the scan that was just done an hour before.
Yeah, so he's got an expanding hematoma. He's got an exam, you said, on his left side that's now deteriorated. He's not moving his left side, you said, Alex. So I think I would probably be pushed now with an expanding hematoma and a patient who has a deteriorated exam, to take him to surgery to evacuate the hematoma with or without a hemicraniectomy.
Yeah, I think it's pretty. I think most people would agree at that point you need to go to the OR. But then the question is, so what do you do at surgery, Rocco? You mentioned craniotomy, craniectomy. I mean, what would be your preference?
Alex, can I say one thing before you go? This is a 61-year-old gentleman. He might be on aspirin Plavix. I would probably ask for a TEG, thromboelastogram, to try to find out whether he has any clotting dysfunction. Otherwise, you're liable to get in a little bit of a mess in the OR.
That's a good point. Now, let me ask you, though, what if you find out he is taking aspirin or Plavix or even Coumadin? Pick any of those types of drugs. Would you wait to normalize his TEG or get some platelets or FFP into him
before
that would go to the OR?
I wouldn't wait. I would just make sure that we had those available coming up and consider, depending on what your facility has, using either PCCs or platelets. But PCCs may actually be helpful in somebody who's been on antiplatelets.
Lori, can you talk very briefly, what exactly are PCCs, and when would you use them as opposed to FFP or factor 7?
The advantage of the PCCs, the prothrombin complex concentrates, is that you actually have all of the factors in the solution. So it may be a little more effective than just FFP. If your facility has it, it is probably, it's been shown to be more effective than FFP, but not every institution has it. If you don't have it, then you're probably going to have to be thinking of your usual platelets, FFP platelets, and or factor 7 if he is on, if it looks like a bad bleeding problem.
Now, what if you happen to find out the guy's on Pradaxa, one of these newer anticoagulant type drugs, a direct thrombin inhibitor? How do you try to reverse the effects of that?
You would continue to try to use your reversal agents like FFP, vitamin K, knowing that it is only going to be about 50% as effective as in this situation as if the patient was on Coumadin.
What about use of factor 7?
Costly drug, but that basically stops everything from bleeding, so it is very, very effective. As an intensivist, though, 61-year-old guy, I would start worrying about the when he comes back in the unit, what kind of thromboembolic events I may be dealing with.
What about
what dose of factor 7 would you give?
Partial doses.
What does that mean? I mean, how many milligrams?
What I've heard around, this is Rocco here, I think the point of TAG is excellent. The nice thing is that they talk about titrating the dose down like 0.1 to 0.2 milligram per kg, yeah, that's right, 1.2, so that it's a much lower dose than what we would give for somebody who's fully Coumadinized. You get a baseline TEG, realize that it takes a good 40 minutes for the TEG to come back, so you're already in the operating room proceeding and correcting based on what some of the earlier results are. The early results of your TEG might show you the time to clot, the time to formation of a clot, and then show you, in fact, what the strength of the clot is. And then from there you might get an idea of, is this person hypocoagulable because of a problem associated with aspirin or Plavix or a direct thrombin inhibitor. But I think, the idea here is that you mobilize your blood bank. You have platelets available. You have, if your institution has PCC available, I think for someone who, is on Coumadin, PCCs are very nice because you don't have to give them the big volume of FFP. You give them a much smaller volume.
Yeah, I agree with you. That's an excellent point to get a tag and think about these issues. And what my institution does, which you can take or leave, is we usually give like 1 milligram doses of factor 7A, which may be enough to stop the bleeding. And we hope that, as Dr. Schroeder said, we're not going to start clotting off arteries that go to the brain and heart and other important parts of the body. The downside, of course, is that in people who are really heavily anticoagulated, it's just a temporary effect. Maybe it dries up for surgery, but you often see a few hours later your INR might start creeping up again. So it is something you need to keep up with.
Was he on Pradaxa?
No, we're just
okay.
Free associating here. So Craig, what would you do if this guy has an enlarging subdural, the jam's deteriorating?
I'm taking him to the OR.
And what would you do there?
Craniotomy. And then I would base the decision on closing the dura on how things looked at the time of closure. So what does that mean? You mean you would, in terms of leaving a bone flap on or off, depends how tight the brain is? Exactly. All right. Rocco, does that sound like what you would do?
Yeah, I mean, I sort of have a very low threshold to leave the bone flap out and, prep the abdomen early on in the setup of the case, because just looking at how tight his brain is in terms of, you don't really see cisterns very well on that right side. It's not clear exactly what his course is going to be. This is very early on in his presentation. I'm sure things are going to get worse before they get better. It's rare that I put the bone flap back in on a scenario like this where this guy has what looks like an early in his course of swelling and edema. Sort of one of those scenarios where if I think about it, I usually leave it out. I mean, the cases where I tend to put it back in early is if the brain is very, very slack, and if it was a different entity like an epidural hematoma, not a subdural hematoma. Here, there's a lot more edema throughout that entire hemisphere than just what we see on the subdural, so that makes me concerned.
Well, I went through the same thought process you did, but my default mode or my bias is a little bit different. I would try to put the bone flap back, maybe just because I've been burned by a lot of complications I've seen in my patients and others from decompressive cranie. But yeah, we went to the operating room, did a usual sort of very large trauma-type flap to make sure we had access everywhere from the skull base on the right side all the way to the midline, from as far anterior to as far posterior as we could get. And took out the subdural without too much difficulty, but actually found a pretty large temporal contusion, which you get a hint of here on the slide, but there was a lot of oozing from a raw temporal surface, so I had to spend a fair amount of time kind of resecting and trying to get that bleeding stopped. Rocco, do you have any special tricks in the OR for something that's sort of just at the edge or just underneath the edge of your bone flap and you're trying to get controlled? You just bipolar? Do you use anything else?
Yeah, there's some nice little agents out there. Sort of what I like is the fibular surgicel. It looks sort of like cotton candy. The fibular surgicel sort of forms a little bit more of a matrix then, and then I use Surgiflow or some of the other injectable agents as well, especially if it's more venous type. And if the patient's coagulopathic, you want to make sure that you're not dealing with that as well. The other thing that makes me concerned, as you mentioned, this sort of contusion is there a problem with a venous sinus or a vena labae injury? Is this part of a venous infarction issue? So that's the other thing to look at as well. Make sure that you don't see a big thrombosed vein on the surface that might contribute to his worsening hemorrhage because of all the venous congestion as well as hemorrhagic transformation of this.
Do you think would you see that quickly in a guy who just had a trauma, even if he had a vena labae injury and thrombosis, you're in the OR a couple hours later? Is that enough time for to have a venous infarction turn into a hemorrhagic mess?
I usually just look at the veins, and you may see the veins actually show evidence of a thrombus within, or very, very dark regions, especially a dominant vena labae type injury. You can't really do much there, but that would certainly push me more towards what we talked about before, leaving the bone flap out.
Another good old trick too that I use sometimes if there's a lot of bleeding is good old hydrogen peroxide and cotton balls. Just have some half-strength hydrogen peroxide, soak some cotton balls, and let it sit there for a while, just like a lot of us use gel foam, and then you put a cottonoid on there to suck the gel foam.
So what happened, Alex?
So at surgery, we also, while the field was open, you had the brain exposed, just put a ventriculostomy in there. We're able to hit the ventricle and just tunnel it out. You bring it out through the edge of the dura, trail it out through a burr hole so it comes out underneath the bone flap, and then tunnel it under the scalp a short ways. And ICP was not an issue at that time. Craig, when would you get a follow-up CT scan?
Probably the next morning, unless there were ICP issues afterward.
Yeah. Or would you be worried about this at all, this contusion, or you think if
Sure.
ICP is okay, you can wait till the morning?
You worry about that blossoming. Absolutely.
So, we did the craniotomy, put in a ventriculostomy. Here's your CT scan, and here's a lot of gel foam, or packing, as a neuroradiologist like to say. The temporal contusion is a little bit bigger. Again, cisterns don't look any worse. You see some blood there along the edge of the tent.
some residual contusion there and some blood along the tent there. So he's doing okay, and now suddenly, nurses are calling saying his ICP is starting to hit 20 and keeps creeping up. So what post-op orders should we have written, Dr. Shutter? So this acute craniotomy comes to the ICU. Do you usually put them on any sort of analgesic, sedation, anything like that?
Typically, yes, low-dose sedation, short-acting agents, fentanyl and propofol are our drugs of choice.
Okay, and do you have blood pressure problems with propofol? You're not too worried about it?
Haven't seen too many blood pressure problems with it. So we'll often keep it very, very low. Typically, we'll start first with fentanyl, like 25 micrograms an hour, and that's it. And then if they seem to be the least bit agitated, uncomfortable, we'll often start with propofol at 10, and just keep it as low as possible.
Are there any other kind of what they call standard sort of tuck-in orders that you do for this guy? I mean, would you hyperventilate or do anything special with the IV fluids or put him on steroids or anything like that?
Tuck-in orders would be to maintain IV fluids at basically a normal rate for hydration, about 1 ml per kilo per hour. As far as hyperventilator status, we aim for normal carbia, so trying to keep somebody's PaCO2 between 38 and 42. So we do not hyperventilate. We do not hyperoxygenate, keeping oxygen goals between 90 to 100, a little bit higher than what a lot of pulmonary critical care doctors will tolerate. They'll allow down to 60. We'll try to keep it closer to 100. ICP goal 20 to 25 typically, and CPP goals usually start out trying to keep it over 60.
It sounds like you basically try to keep it more or less normal, right?
Yeah.
Just try to maintain status quo, without going too wild. But so what do you do now when this guy, you've written all those orders and he was behaving overnight, but now it's the next morning and the nurses say, his ICP is starting at 25, going above 25, and they're draining the ventriculostomy pretty frequently, and they get a good flow of CSF. ICP comes down for a little bit, but it keeps drifting up.
We would start with increasing sedation first. As far as the medical side, the surgeons would have been contacted as well. There probably would be a repeat head CT. We have the advantage of a portable head CT at bedside that we could look, not have to take the patient anywhere to make sure that other contusion has not blossomed anymore. Increased sedation would be our first line. And we might allow the PaCO2 to drop down to 35, but we're not going to actively hyperventilate.
Okay, now his ICP is hitting like 35, and they're draining and it's really not coming down much at all. So what I'm asking is, what would be your next step then? So you've got some good sedation going on, you're draining CSF, you mentioned maybe kick up the minute ventilation a little bit.
Right.
What's next?
Diuretics.
I would go to either mannitol or hypertonic saline.
Okay, and Craig, what do you mean by diuretics?
Well, either mannitol or or hypertonic saline, as she indicated.
Would anybody use Lasix?
I don't tend to use it as a first line.
Yeah. Okay. Craig, talk about how would you give mannitol or 3% or 23.4%. What do you use, and how would you write the orders?
Well, my sort of first line would be mannitol, and usually initially would give 1 gram per kilo, and then maybe lower doses, such as 25 to 50 grams, periodically and following serum osmolarities.
Okay, so be a little more specific. I mean, periodically, how often would you give it, and how often would you order serum osmolarities and things like that?
Every 6 hours, typically.
Okay, Rocco, you have anything to add so far?
Yeah, I would probably be more inclined to use 3% or hypertonic saline with the objective of keeping sodium up in the 150s. My concern with dehydrating agents and mannitol is that if you're dealing with a problem that may be involving, venous injury, then you're actually sort of making this scenario worse by, decreasing flow through the veins that are related to the contusion. And I think, that's sometimes a mechanism for making things worse. Mannitol, Lasix is more of a short-term agent. I think hypertonic saline may in fact work better from a physiologic standpoint, especially with looking how much contused brain that you're dealing with here.
Well, what about the strategy of giving mannitol but then chasing those boluses with crystalloid? So if you believe that mannitol works largely through a viscosity lowering effect, so you lower the viscosity of the blood, which means that the arteries in the brain can shrink a little bit because you're maintaining the same bulk blood flow through a smaller pipe, and as the cerebral blood volume decreases, ICP goes down that way. And yet, to prevent the diuretic effect that you mentioned, you just chase it with some crystalloid to try to they don't get too dry.
Yeah, I think what happens is that you tend to hurt the lungs with this strategy. And yes. I think when you look at a hypertonic saline agent, it's actually more beneficial because it stays intravascular. You have less associated problems with, delayed leaky lungs. This might work for day, 2 or 3, but by the time you get to day 4 or 5, now you're dealing with, significant problems associated with pulmonary edema and oxygenation issues and hypoxia as a result. I think using the hypertonic saline sort of avoids that scenario of problems with this chasing saline boluses from basically causing more pulmonary capillary leakage.
But how would you write for use 3% or anything more concentrated?
Yeah, so it depends on what their baseline sodium is. If their baseline sodium is below 140, we put them on the 3% drip, a continual drip. 25
and what rate and how long do you give that for?
Yeah, 25 to 50 cc's an hour. Early on, within the first 24 hours, we're checking between every 4 to 6 hours.
And that's a continuous drip. It's running continuously every hour or 25?
Correct. So that's somebody who you're trying to get up to target, and our target in this scenario, let's say, is up into the low 150s. If you have someone who, on the other hand, has elevated ICP into the 130s, or excuse me, elevated ICP into the 30s, and you're trying to get their sodium up as a response to that, then we give it as a bolus. And the boluses that I've given include 3% up to 23%. And the 3% we give as a 250 bolus, depending upon what your target is, in this case, usually between 150 and 155. And that usually has a pretty dramatic, rapid response in terms of ICP, but it may not be sustained.
So at what point do you have to stop that? I mean, you're giving it, and ICP is still a challenge. Yeah. When do you have to turn off hypertonic saline?
Yeah, so I don't necessarily completely turn it off, but then I might have to take it up a level in terms of different intervention. If the ICP is sustained above, up into the upper 20s, lower 30s, despite hypertonic saline, despite a sodium, let's say, that's in the 150s. So if their sodium is in the 150s, then I need to take it up a notch.
But do you have a serum sodium or osmolality at which you'll stop the hypertonic saline?
Sure. If their serum sodium is 155, I don't keep pushing it. If their osms are greater than 320, I don't keep pushing it.
Okay, so Dr. Shutter, Dr. Amonda has just got out of town for the weekend, and you inherit this patient. And unfortunately, as he said, the serum sodium's in the high 150s, osms are 340 or so, and ICP is still a real problem. It's creeping up into the 30s. Well, what would you do next?
Well, one thing I would have checked, and I echo Rocco's sentiments as far as hypertonic saline drips, 3%. We make sure that we have a total fluid infusion. What I have seen is people start the 3% and don't back off their maintenance IV fluids, and you're pouring 200 cc's an hour into these patients. So you have to have a maintenance IV fluid rate so you're not overloading them. If I see there's any sign that maybe someone had forgotten to do that, I might actually use some gentle diuresis to try to see if that will help lower the ICP. If it looks like they've done it perfectly, sodium's in the 158, 160 range, and ICP is still a problem, I'm going to start thinking of what other things might be contributing to my ICP issues. Are they having seizures? They were probably on, I hope they were on prophylactic anticonvulsants. We tend to do continuous EEG monitoring here to look for seizures. I would try to make sure that was controlled. I would look for, are they having temperatures? Is there an infection going on? Is there something else we can treat? If I've ruled out all of those, and now you're getting into kind of a higher tier of what are your options, we would start thinking about either therapeutic hypothermia and cooling the patient or to consider a test dose of barbiturates. We don't tend to go to those often. If he was where you had been, Alex, with you and you managing him, and you would put his skull back on, I would be trying to talk to you about, is there any role for decompression at this point?
Yeah, that's exactly the sort of thought process we went through with all those things. And it's funny, just to present a little bit of a counterpoint here, I sort of have the opposite practice in terms of using hyperosmolar therapy. In my experience at least, I've seen a fair number of patients where the sodium was deliberately driven up very high, and oftentimes it only seems to work for a day or two until the osmolality within the brain sort of equilibrates, and then I've been stuck when I wish I could give more mannitol or hypertonic saline, but I can't because the osms are fairly high. So I'm still a big fan of the frequent mannitol and chase it with a crystalloid, which, again, seems to prolong the number of days with which you can get away with that before you have to stop. But, again, it's interesting we have different takes on that. But we decided not to take his bone flap off, although that certainly might be an option in some patients. But we did do, just as you said, Lori, we cooled him down, hypothermia, and even used barbs also. So this guy was really up against the wall, and just when it looked like things might start spiraling out of control, his ICP came down. So we were able to, stop the barbs, warm him up, and, go with less aggressive sedation, gradually back off on those things. I think the point about the hypothermia is worth making that earlier this year in February in a journal called Lancet Neurology, the second NABISH trial published its results. NABISH is National Acute Brain Injury Study, hypothermia. And the short answer is that there was no benefit in those patients. But that was when hypothermia was given right off the bat as soon as people came in the door. What we're talking about here is a very different kind of rescue therapy for someone who's really having a lot of ICP issues despite all your other treatment. And again, in the NABISH studies, they were just cooled for 48 hours and then rewarmed over a period of 16 hours. So when you rewarmed them, it took 4 degrees to get to 1 hour. And just kind of informally talking to a lot of people at meetings and seeing what's out there, it seems like a lot of folks may continue to keep them cool for more than 48 hours, may find benefit from temperatures at 35. You may not have to go to 33. And again, if you rewarm them, just go a lot more slowly. So there's still a lot of potential there in terms of hypothermia that hasn't been utilized. I'm sure we'll see future studies.
So what happened next with this patient?
He got better. We stopped all the sedation and gradually kind of switched. As Lori had said, we had him on some fentanyl, propofol, Versed at various times, backed off all of those, and got the ventriculostomy out and got him out of the ICU.
Yeah, Alex, the points I would add about the NABISH-2 is that if you look at the study population versus the control population, they didn't effectively reduce ICP with hypothermia. And I think, that's sort of an important lesson, is that if you're going to use hypothermia to control ICP, you got to reduce the ICP.
Well, see, it's funny that I think that's a great point, Rocco, and we could argue about that a long time. But I think the way the data are kind of collected and reported, what would happen is ICP would be okay for a couple of days, but then it would. I remember vividly a couple of patients when it would start shooting up when you would begin rewarming. You know,
right.
then you're thinking, now what do we do? You know, do we do decompression or barbs or something?
Well, it brings up two major points, and one I think is that one of the reasons why people can still have elevated ICP in the presence of using hypothermia is because they're shivering. So unless you're controlling the shivering properly,
you definitely need to give adequate sedation and often almost always paralyze them too, no question.
Right. And then the other item is, I think the rewarming phase is probably one of the most critical phases, and that might take 3 to 4 days, and you might have to go less than a degree per day. And we typically titrate our rewarming to our intracranial pressure so that we're not seeing elevations in ICP as we rewarm a patient. And you know, that may in fact cause you to extend your period of hypothermia more than 2 days. In fact, some of the other studies have shown better results when the hypothermia was closer to 4 to 5 days.
Yeah, that's exactly it. Or even when you're rewarming them, you may have to kind of go back down. You know, you try to rewarm a little bit and you're having more ICP issues, just go back to where you were, give it a little bit more time, and then try to warm them up. So, yeah, I agree with you completely.
What was interesting, the patients that did the best were the ones who got the combined therapy, although it was a very small patient population. But those who got both the surgical decompression, with or without craniectomy, either craniotomy or craniectomy, surgical decompression of a mass lesion, and then cooled, did better compared to the other patients. And that was a small group, but it may in fact lead to a better paradigm where it's, like you mentioned, it's being used as a rescue therapy in conjunction with surgery, not as a sole therapy.
Well, I think and I asked that question specifically because we looked at that, but I think the point is that hypothermia benefited the patients who needed a craniotomy for a mass lesion, who had a clot in there and had it evacuated early. It had almost no effect in the patients who was sort of your diffuse brain injury, you know, a few scattered petechial bleeds, but nothing to operate on.
Right. Okay. So I think we face these diffuse brain injury patients don't respond very well to surgery. They don't respond very well to hypothermia. They don't respond very well to barbs. You know, they're a very tough nut to crack.
And maybe if you extrapolate the DECRA results, they don't respond well to decompressive crani either.
Right.
Rocco, can I ask, when would you, we've seen some of those patients that they don't have pressure problems, ICP problems for the first couple days, and everyone starts thinking of taking out monitors, but then on day 5 or 6 it starts going up. When do we need to worry about traumatic-related vasospasm?
Yeah, it's actually during that end of the first week, and so it's nice to have some baseline PCDs on a patient when they come in the door with their multimodal monitoring, so you know where they start in terms of what their velocities are. And then they may be, in fact, going into a traumatic vasospasm picture at the end of the first week, beginning of the second week. You know, we sort of think that they're out of the woods, but when their ICP shows a late incline, then you have to start looking at these other entities. And they're definitely less common, probably less common in civilian sector than what we see in the military, but you want to start looking at what your transcranial Dopplers show. If you have a Lycox monitor, to see if you see evidence of desaturation. If you have an EEG, to see if you see evidence of what may in fact be a change in terms of blood flow related electrical activity.